Good morning, everybody. This is Deniz Demiryurek from Turkey. Today we are going to talk about thread lifting and dangerous zones for the anatomy of the upper third phase. During thread lifting, we are going to share the dangerous zones, the risky zones for our complications. Before we continue, I would like to introduce myself. My name is Deniz Demiryurek. I'm professor, working as a professor of anatomy, as well the head, as well the dean of the Hacettepe University Faculty of Medicine. I have some official responsibilities, plus, which is my proud, I'm also a member of the Meds Academy, who is the representative of Aptos in Turkey. What we do, we arrange training programs in different levels for e-learning, for full-face aesthetic cadaveric courses. Now we are going to make the 10th coming soon. As well, we arrange full-face aesthetic hands-on courses, and I'm so proud to work with this team. Today we are going to talk about the anatomy of aging, the layers of the face. We are going to talk about the anatomical structures during our treatments which can be damaged, and we are going to talk how we can avoid to damage these anatomical structures. Let's start. What we do, we plan always a successful and effective treatment for the aging, but the main rule is we should understand the change, what happens due to aging related with the anatomy, then we will manipulate. For the bony structures, we have the resorptions and we have the enlargements. The resorptions of the cavities, the enlargement of the holes for the bony structures change the age-related seen on the face. The skin quality decreases, the spaces expand, and due to the aging, the fatty tissue at the buccal region decreases and the submandibular region increases. For us, for the thread lifting topic, the ligaments lose their tightness, tone, and strength, and they increase the fixing and the holding power capacity. They decrease the fixing and the holding power capacity. And for the muscle aging, there is a discussion about is there any change or not. From my side, the muscles do not age, but the power of the muscle decreases. What we do, we make treatments, either to the surface or with the help of the injections, and more on, we have some minimal invasive procedures for the treatment options. What is the purpose? The purpose is regeneration, the purpose is gaining the volume, and the purpose is lifting the face. But not every time. We have sometimes bad results, unexpected results. These might be explained by the patient-related, treatment-related, or the practitioner-related factors. Among these, patient and practitioner-related factors can be explained with the anatomy. But for the treatment, of course, depends on the product we are using. Let's continue with the anatomy. For the face, during our medical educations, we have been told for two-dimensional anatomy on the atlases, but it doesn't work like this because we have the third dimension, which is the depth. As well, we have the fourth dimension, which is the movement-related relation changes. How it does happen, because especially for the thread lifting, if you think about the relations of the anatomical structures during the activities, you can have better results. That's why I would like to continue with the layered anatomy of the face. The first layer, as you all know, is the skin. After that, we are going to face with the second layer, which is the superficial fat tissue made by the connective tissue. Third layer, if we continue deep, is this mass. Fourth is the deep fat, and the fifth is the deep fascia, which is attaching to the periosteum. For the layered anatomy, that's one of the pictures which I admire a lot. You can see the detail 5 layers of the anatomy of the face. For the skin, it's thicker in male. The thinnest zone is the lids. The thickest zone is the buccal region. Of course, epidermis thickness changes due to the races. But if we accept the units as the upper eyelid 1 unit, you can see 1, 3, 1.5, approximately 3 unit thickness for the skin. The second layer, when you remove the skin is which we face superficial fatty tissue, in other words, subcutaneous tissue. For the subcutaneous tissue of the upper 1/3, we have the central forehead, middle forehead, and lateral, especially temporal cheek fat subcutaneous tissue, splitted into compartments. And this slide, which is my favorite, best subcutaneous tissue showing slide, is made by my friends, my colleagues, by Katofana. It is admiring picture of the subcutaneous fatty tissue. When you continue, you reach the 3rd layer, SMAS. SMAS is the explanation of the superficial musculo-aponeurotic system. Why we have it? It contains our mimic muscles. It contains superficial fascia. Superficial fascia of the face is the continuation of the superficial fascia of the neck. It continues at SMAS. On the temporal region, it again continues at superficial temporal fascia, and finally, galea aponeurotica. Without any interruption, it continues from here to the top of our head. What does it mean? If we make a manipulation for the superficial temporal fascia, you can see some results on the face as well on our neck region. This is the dissection of the cadaveric, which shows the continuation of the superficial fascia of the neck, the face, and the temporal facial area. And this mass is usually used for surgical lifting procedures. And it's an advantage for us because it protects our facial nerve and the vessels which are placed under this mass, for it's a protector for our vessels and for our nerves. When you open SMAS, we face the expression muscles, our mimic muscles. The mimic muscles related with the upper 1/3 is mainly the frontal muscle, temporalis muscle, orbicularis oculi, procerus, the procerus supercilii, and corrugator supercilii. What I would like to mention is the layered anatomy of the muscles. Most superficially, we have the orbicularis oculi superficial layer. When you go deeper, you can find out the frontalis and the corrugators, and the most deeply, you can find out the temporalis muscle. Now it's time for the 4th layer, deep fascia. It is a continuation of the deep cervical fascia, but we have an exception. It's not continuing like the superficial fascia, it has interruptions. It continues deep cervical fascia, finalizes here at the neck region, changes its name, parotidomasseteric fascia. Another interruption is made at the zygomatic arch. Afterwards, it will continue as deep temporal fascia with 2 layers, superficial and deep. Here is the parotidomasseteric fascia. Here is the temporal fascia, which is not continuing as 1 layer with interruptions you can see. And inside the deep fascia, we have the deep fat. As well, some fascia thickens results with ligaments which are given the name retaining ligaments. These ligaments traverse between the layers of the deep fascia and hangs our face fixes our face. And this deep fascia, with its attachments, it makes organizations like retroorbicularis oculi fat pad, suborbicularis oculi fat pad. Now it's time for the retaining ligaments. They start, if they are real, from periosteum to skin, like a tree branches organization. The facial ligaments are first described by Fumas. The activity for the ligaments is working against gravity, anchoring structures, skin to the deeper structures. When you examine them, you can see cylindrical shape deeply. As well, they sometimes organize lamellary superficial structures, and they arrange fat compartments. In morphological forms, if you examine the retaining ligaments, you can find them as adhesions or septums or real ligaments, true ligaments. If we are meaning true ligament, that means it has an attachment from periosteum to skin. Which of these we have? We have the zygomatic ligament, which is positioned posterior to the zygomatic minor muscle, and it attaches zygomatic arch to the dermis. As well, we have the orbicular real ligament, and the third real ligament, true ligament of the face, is the mandibular ligament. If it's not true, that means we don't have any bony attachments. As I mentioned, you can see them either adhesion, here adhesions, or septum, or ligament organization. That is mean we have the attachment to the bone. I'm reminding one more time. And if you don't have bony attachment, you can see the name false retaining ligaments. We have many of them. And as well, there is no consistency with the definition of them. Some of the authors say orbitomalar ligament. Some of them say orbicularis retaining ligament. Some of them say zone of adhesion. Some of them superficial temporal septum. You can find that in different definitions when you are examining the literature. Here is the retaining ligaments of the upper face. Here, the superior temporal septum, inferior temporal septum. These unite and form temporal adhesion. Here, you can see the orbicular retaining ligament. And this is one of the best slides, which I like so much. Here we have the temporal ligamentous adhesion, lateral orbital thickening, zygomatic ligament, and mandibular ligament. That is why we mention them. They are the real ligaments working against gravity. When you check the deep fascia, as I mentioned before, it is the continuation of the deep cervical fascia with interruptions. And on the zone of the temporal, we are talking about the deep temporal fascia with two layers, superficial and deep. The deep temporal fascia usually positioned at the temporal region. But if we are talking about fascia, we usually, as an anatomical aspect, the fascia packages a muscle. For the temporal region, it is an exceptional situation because all the layers of the temporal fascia, both superficial temporal fascia and two-layer deep temporal fascia, it is above the muscle. Muscle attaches directly to the periosteum. While doing that, here we have the temporalis muscle. On it, we have the deep temporal fascia, and on it, which we cannot see here, we have the superficial temporal fascia. And between the two layers of the deep temporal fascia, we have the deep temporal fat pad. It is a necessity for protection of what we are going to talk about this. What we did, we talked about the layers of the face, the skin, second layer superficial fat, third layer mass, fourth layer deep fat, fifth layer deep fascia. Let's talk about the vascular supply. Mainly, we have two arteries giving blood supply, internal carotid and external carotid for the rest of the face. But if we go more detailed, we are going to, for the upper 1/3, two arteries giving main blood supply. Superficial temporal artery and the ophthalmic arteries branches supratrochlear, supraorbital. As well, facial artery will give blood supply to the upper zone if it continues and makes the attachments, make the anastomosis with the upper zone arteries. It will be a best blood supplying organization. For the vascular supply of the face, superficial temporal artery continues upwards, splits into two, frontal branch and parietal branch. The frontal branch of the superficial temporal artery can be seen with a well-lighted area. Here it is. It is dangerous. Why? Because you need to feel the pulsation. If you do not feel, if you do not realize, it might cause serious bleeding complications. And usually, the upper 1/3 of the face, the veins of the arteries accompany them so closely. But we have an exception. The exception is the superficial frontal branch of the temporal arteries vein split a little bit more anteriorly. For the forehead, we have three arteries giving main blood supply. One of them is the supratrochlear, the other one is the supraorbital, the third one is the frontal branch of the superficial temporal artery. For the root of the neck, we have an additional artery, which is the dorsal nasal artery. The veins are accompanying to the arteries, they are close with them. And for the temporal zone, as I mentioned before, we have the superficial temporal artery, frontal branch. How about the course of the frontal branch? It is above the eyebrow, 2 centimeters. You can feel the pulsation. You should be aware of this artery for manipulating this zone. Otherwise, you might face with serious hemorrhages. Here is the temporal artery course. Starting from the superficial temporal artery, goes anterior and gives blood supply to the lateral side of the forehead. As I mentioned, the temporal vein is more anteriorly positioned when you compare with the artery. Even though you might feel the pulsation of the temporal artery, you should be aware of the temporal vein. Otherwise, you might give a serious damage with resulting large zone hematomas related with the temporal veins. Let's remember the facial artery here. It starts from the lower side of the edge of the mandible, continues upward, gives the inferior labial, superior labial, then under the nasolacrimal sulcus, it changes its name in the angular artery, and finally at anastomosis with the dorsal nasal arteries. Here's another view showing the facial artery very well. And the third artery, although it is giving main blood supply for the middle third of the face, its end branches gives to the medial side of the orbital zone. The veins are the same names related with the arteries. Now it's time for the nerve supply. Trigeminal nerve is the main nerve sensor of the face region. It has 3 branches: ophthalmic, maxillary, and mandibular. For the upper 1/3, ophthalmic nerve is the main sensory nerve. And here you can see the branches: supraorbital, supratrochlear, infratrochlear, and as well external nasal of the ophthalmic branch. Would you please follow up? The supraorbital nerve zone continues laterally and posteriorly. That is why we can feel pain if we are manipulating this zone on the back side or the lateral side of our head due to the innervation area of the ophthalmic nerve. For the temporal region, mandibular nerves, especially here, the auriculotemporal branch is responsible for the innervation. And the rest, the lateral side of the ophthalmic area, will be felt by maxillaries, zygomaticofacial, and zygomaticotemporal branches. Here is the main nerve for the mimic activities of our facial nerve. Although it emerges from the stylomastoid foramen, splits into upper division and lower division, the superior part of the facial nerve, which will be responsible for the innervation of the forehead and orbicularis oculi, which is the given name frontal branch, is one of the most important nerves, especially might cause a danger for our procedures. It continues superiorly, and usually for the face region, although it has been protected by SMES, it is positioned under the SMES. For the temporal zone, it has a risky area. Where is it? Under the zygomatic arch at the middle 1/3. You can see the facial nerves course, which is first defined by Pitangui. Here it is. And we need to be aware. We need to think that there might be a dangerous zone related with the facial nerve at the middle 1/3 of the zygomatic arch. And this facial nerve frontal branch continues superior anteriorly and finalizes at the upper 2 centimeters of the eyebrow. That's why for the facial nerve, I would like to mention the dangerous zones. Here we have the zygomatic arch dangerous zone. The second dangerous zone for the facial nerve is the mandibular region, but now we are talking about the 1/3 of the face. Then let's continue what we have. Facial nerve, although it is taught as the danger zone, it has been protected with a structure. Which structure protects this is the temporal fascia 2 layer. With inside the fat, it takes the facial nerve inside and makes protection for its damage. Why we are talking, if we do not pierce this layer, we cannot damage the facial nerve. How we are going to do this? For manipulating the thread lifts, we should stay more superficially so that we can protect it. Then let's remember the anatomical structures which might be damaged, especially for thread lifting. First, we have the superficial temporal artery, frontal branch. We have the facial nerve, frontal branch. And as well, we have the middle temporal vein for the upper 1/3 of our face. What we talked the anatomy of ages. We have talked about the layers of the face. We talked about the structures which might be damaged, and we talked about how we should avoid these damages. I would like to thank you for your attention and hope to see you soonest face to face. Bye.